Hello, and thank you for enrolling in the American Lung Association Cessation Navigator training. This webinar will take approximately 1 hour to complete. You can pause this presentation at any time and take breaks as needed. You also are able to leave and come back. The webinar will save your place. The voices you will hear during this presentation are Rachel Hunley and Shambria McBrayer, the Division Managers for the American Lung Association Smoke-Free Multi-Unit Housing Initiative. The Cessation Navigator training is a two-part training. Part 1 focuses on Cessation Navigator's purpose, role, and responsibilities, the history of the American Lung Association and our core beliefs, tobacco basics, and lung cancer screening information and resources. Part 2 focuses on the Cessation Navigator training, Ask, Advise, Refer, and assessing tobacco cessation resources. Let's begin with the roles, responsibilities, and purpose of the Cessation Navigator. The purpose of a Cessation Navigator is to conduct brief interventions to encourage quit attempts and connect tobacco users to evidence-based cessation services like freedom from smoking. Generally, these are members of the community and there is no medical training required. To become a Cessation Navigator, a person must be a non-tobacco user, must complete tobacco basics, which we'll cover today, must complete how to help people quit, which again we'll cover today, and work with your local lung association staff member to begin working in the community. Cessation Navigators is a new concept to the American Lung Association. Cessation Navigators are people trained by the American Lung Association to talk to somebody about tobacco use in a way that makes a real difference. So what can they do? They can ask someone if they use tobacco in a down-to-earth way. They can recommend quitting in a way that makes it an attainable goal. And they can connect them with resources to help them quit, including our signature Freedom from Smoking program. Here are some requirements of a Cessation Navigator. The Cessation Navigator can be a resident or staff personnel of an individual public housing property or community partner that has regular contact with PHAs. The Cessation Navigator cannot have used tobacco in any form, to include e-cigarettes, for the last 6 months. The Cessation Navigator has an interest in helping their neighbors quit smoking, and the Cessation Navigator must submit a monthly report to the project manager of outreach efforts. Cessation Navigators play a very important role in the Smoke-Free Public Housing Initiative. Cessation Navigators will talk to their friends and neighbors within public housing settings about their tobacco use. The American Lung Association staff will provide additional training, local cessation services, and incentives for Cessation Navigators. In this project, Cessation Navigators will first focus on brief tobacco interventions and referrals, and then add lung cancer screening to their conversation. Let's talk more about the American Lung Association. The American Lung Association was first established in 1904 as the first voluntary health organization to fight against tuberculosis. In the 1960s, the American Lung Association began to establish the first tobacco control work. This work prompted the Surgeon General's first report, helped over 1 million smokers quit, was a major backer of smoke-free environments, and began working to improve tobacco cessation coverage. Other lung health priorities included asthma prevention and control, lung cancer and COPD work, and to defend and enforce the Clean Air Act. The American Lung Association has 8 core beliefs about tobacco cessation. 1, everyone can quit. 2, you don't have to quit alone. 3, every moment you don't smoke is a success. 4, you had to learn how to smoke, so you have to learn how to quit. 5, it takes most smokers several tries before they're able to quit for good. 6, one size does not fit all. 7, combine medication with a quit smoking program for the best results. 8, a slip isn't the same as a relapse. Let's transition to the tobacco basics portion. The first part of this presentation will cover tobacco use rates and tobacco disparities. So, who smokes in America? For these next few slides, data and information was pulled from the National Health Survey of 2017. Let's first discuss demographic characteristics. There are several demographic characteristics that may influence patterns of tobacco use. Those characteristics can include age, gender, race and ethnicity, geography, income and education, occupation, behavioral health, and sexual orientation. This slide reflects the current tobacco use rates by age in the United States. As you can see, the ages 25 to 44 for both any tobacco products and any combustible tobacco product usage is the highest. When broken down by gender, males have the highest percentage of usage for both any tobacco product and any combustible tobacco product. Let's take a closer look at race and ethnicity. According to the survey data, American Indian and Alaska Natives have the highest use rates of any tobacco product or any combustible tobacco product, followed by those with multiple races. The trend then differs, with whites having the higher rate of any tobacco product, but blacks having a higher rate of any combustible tobacco product. Take a minute to review the other rates. The current slide illustrates adult smoking rates by income in the United States. As you can see, those with a ratio family income to poverty threshold greater than 1 have a smoking rate of 25.3%. Those with a ratio of family income to poverty threshold between 1 and 2 have a smoking rate of 21.2%, and those with a ratio of family income to poverty threshold with greater than 2 have a 12.7% smoking rate. Level of education also influences smoking rates. As you can see, those with an education level of 0 to 12 years have a smoking rate of 26.1%, and those with a GED have a smoking ratio of 42.6%. Those with graduate level degrees have an 8.3% smoking rate. This slide reflects the current adult smoking rate by occupation. I won't go over each of the individual percentages, but as you can see, those with the most hands-on and technical requirements such as construction, transportation, and cleaning have higher smoking rates than those with college-level degrees such as architecture and engineering. As you can see, sexual orientation also influences adult smoking rates. For those who identify as heterosexual or straight, they have lower percentages of usage of any tobacco product or any combustible tobacco product than those who identify as lesbian, gay, or bisexual. Mental illness also influences smoking. More than 1 in 4 adults, 25%, with mental illness smoke cigarettes. About 3 of every 10 cigarettes smoked by adults are smoked by adults with mental illness, and nearly 1 in 5 adults, or 47.9 million, have some form of mental illness. Quiz time. Let's take a few minutes to answer a couple questions. Who has higher smoking rates, males or females? If you answered males, then you are correct. Men are more likely to be current cigarette smokers than women. More than 17 of every 100 adult men, or 17.5%, and about 13 of every 100 adult women, or 13.5%, currently smoke. Next question. What state has the highest smoking rate? I'll give you a hint. Think traditional tobacco growing. If you answered West Virginia, you'd be correct. West Virginia has a 26% smoking rate. So, then what state has the lowest smoking rate? That would be Utah, who has a smoking rate of 8.9%. Last question, true or false? Smoking peaked in the 1960s when approximately 1/2 of men and 1/3 of women smoked. The answer, true. What changed public awareness? That would be the Surgeon General's report in 1964. Approximately 1 year later, in 1965, Congress required all cigarette packages distributed in the U.S. to carry health warnings. In 1969, cigarette advertising on TV and radio was banned and became effective in 1970. Let's now cover effects of tobacco use. We'll start with tobacco use and health. Smoking is a leading cause of preventable disease and death in the United States. Close to 500,000 premature deaths per year are directly associated with smoking, which then attributes to about $332 billion in direct health care expenditures and lost productivity annually. Since 1964, 20 million deaths have been due to smoking. Secondhand smoke is also harmful to children and adults. There is no risk-free level of exposure to secondhand smoke. Since 1964, about 2.5 million deaths were due to secondhand smoking. And between 2011 and 2012, about 58 million non-smokers were exposed to secondhand smoke. As mentioned during our quiz, West Virginia has the highest smoking rates in the U.S., and Utah has the lowest number. Take a look at these rates compared to the United States. For every puff of a cigarette, you increase your heart rate, you increase your breathing rate, you constrict your blood vessels, and you decrease oxygen carrying capacity in the blood. Here are a few of the short-term effects of tobacco use. It lowers your lung function, it increases your resting heart rate, it compromises the smell of your clothes and hair, it creates or develops shortness of breath, it causes increased phlegm, it diminishes your capacity in sports, it's an addiction to nicotine, your skin will appear pale and unhealthy, you often feel tired, it decreases your sense of smell and taste, it produces bad breath, and it creates severe wheezing. More than 16 million Americans are living with a disease caused by smoking. For every person who dies because of smoking, at least 30 people live with a serious smoking-related illness. Smoking causes cancer, heart disease, stroke, lung diseases, COPD, which includes emphysema and chronic bronchitis, and smoking is a known cause of erectile dysfunction in males and infertility in females. Worldwide, tobacco use causes nearly 6 million deaths per year, and current trends show that tobacco use will cause more than 8 million deaths annually by 2030. Cigarette smoking is responsible for more than 480,000 deaths per year in the United States. This is about 1 in 5 deaths annually, or 1,300 deaths every day. Lung cancer, heart disease, and COPD are the top 3 fatal tobacco-related diseases. Smoking can cause cancer almost anywhere in the body. Smoking causes cancer in the lungs, trachea, bronchus, esophagus, oral cavity, lip, nasopharynx, nasal cavity, larynx, stomach, bladder, pancreas, kidney, liver, uterine cervix, colon and rectum, and it also causes leukemia. Let's move on to nicotine in the brain, the three-link chain of addiction. Nicotine and addiction. Cigarettes are about 600 ingredients and 7,000 chemicals, and of those ingredients, at least 69 are known carcinogens that cause cancer. Nicotine is an addictive agent in cigarettes and are put into cigarettes in the following ways: intentional, to make a cigarette burn; incidental, because of like the pesticides in the tobacco where it's grown; and for a chemical reaction when the cigarette is lit and burning. So, true or false? Nicotine has a very flavorful taste, but it smells awful. The answer, false. Nicotine is odorless, tasteless, but very powerful and addictive. So what is nicotine? Nicotine is an addictive constituent in tobacco, but it's also poisonous. 2 to 3 drops, or about 60 milliliters, on your tongue can kill you. It's more poisonous than cyanide, and 3 to 4 cigarettes can be fatal if eaten by a small child or pet. Nicotine takes approximately 10 seconds to travel to the brain. While certain illicit drugs affect certain receptors of the brain, like heroin and cocaine, nicotine, a legal substance, affects all receptors. The cycle of addiction. Cigarettes deliver nicotine to the brain in 7 to 10 seconds after the first puff. Nicotine acts on certain receptors in the brain, releasing hormones and neurotransmitters, including dopamine, norepinephrine, and serotonin. Smokers feel pressure, reduced tension, appetite suppression, and enhanced performance. Nicotine accumulates in the body. Each additional cigarette creates a greater tolerance. The brain's chemistry changes and tolerance develops. Absence of nicotine causes withdrawal and/or recovery symptoms. As the day goes on, smokers need more cigarettes to relieve withdrawal or recovery symptoms. Overnight, diffusion of nicotine throughout the body helps smokers regain his or her sensitivity to nicotine. The cycle then starts over. Tobacco dependence is characterized by a three-link chain of addiction: biological, psychological, and social-cultural. Individuals must learn to manage their addiction, unlearn automatic behavior, and substitute healthy alternatives. As mentioned previously, the American Lung Association believes there are 3 aspects to tobacco addiction: biological, which is a physical response; psychological, which is a mental response; and social-cultural, which is the social response. Addiction occurs when a substance, like nicotine, enters the brain, activates the brain's receptors for that substance, and produces pleasure. The first link in the chain is the biological or physical addiction. These symptoms include: it decreases your anxiety, normalizes mood, relaxes the GI tract, suppresses an appetite, increases heart rate, stimulates nicotine receptors, encourages neurotransmitters to release, increases rewarding and arousal feelings, and produces withdrawal symptoms. The second link is the psychological or mental addiction, often noted as the hardest to break. Over time, smoking becomes an automatic behavior that needs to be unlearned. After smoking or quitting smoking, emotions can overwhelm the quitter. Another important part of psychological addiction is the way certain activities and environmental cues can trigger the urge to smoke. Tobacco products are often used as a result of environmental cues in which smoking becomes an automatic behavior. Can you name a few smoking cues or triggers? Some common triggers are having a cup of coffee, a glass of wine, before or after sex, meeting with friends, driving in cars, designated smoking areas, coping with stress and emotions, and pleasurable activities. The final link is social cultural or social influences. It's influenced by the peers, parents, or other family members who use tobacco. It becomes part of your social and or cultural practices. So taking a break at work, attending a barbecue, maybe going golfing, or gathering with friends. And it becomes a ritual or expected behavior. The desire to socialize and fit in with peers is a major reason people begin to smoke. As we mature, social factors play a role in our continuing to smoke. Smoking with coworkers, friends, or family members can provide important opportunities to socialize that are not otherwise available. People who smoke may be reluctant to give up those opportunities. Let's go over e-cigarettes and other tobacco products. Statewide smoke-free air laws cover more and more states now, and some states have had successes increasing the cigarette tax. As cigarette smoking rates have dropped, the tobacco industry has created new products to keep users hooked and find new customers. These products include e-cigarettes and other tobacco products. E-cigarette is a general term used to reference an array of products that simulate smoking. These products are getting a lot of attention and the sales are increasing. As of the end of 2017, Juul e-cigarettes had the greatest market share among e-cigarette brands. An electronic cigarette is an oral device that can be used to simulate smoking and that produces an aerosol of nicotine and or other substances. They take many forms. E-cigarettes are also known as e-hookahs, hookah pens, vape pens, vaporizers, e-cigars, and e-pipes. Newer models even look like USB flash drives or other items. E-cigarettes are generally battery operated and use a vaporizer to heat a refillable cartridge that then releases a chemical-filled vapor. They come in an array of flavors. Each e-cigarette is different. Some can be customized with the concentration of nicotine in the flavored juice, the amount of the draw, and the temperature of the hit. The long-term health consequences of e-cigarettes is unknown. Other tobacco products, or OTP, represent products that contain tobacco but are not cigarettes. These products aren't safe alternatives. They can also cause cancer, heart disease, and other health issues. Some examples include chewing or spit tobacco, snus, dissolvables, cigars, or cigarillos. So, what's the problem? Tobacco companies are putting a lot of money into creating and marketing these products. And that's a problem because of their packaging, shapes, and flavors. To the unseasoned eye, they are almost indistinguishable from candy and mints. And who likes candy? Kids. These products are cheap because they're not taxed in the same way cigarettes are. As mentioned before, most of these OTPs are available at tobacco realtors statewide. Some OTPs are even found on the sales floor, sometimes right next to gum and candy, as shown here. Another popular place to display them is at the point of purchase. Although the new FDA law that was implemented in 2009 regulated flavored cigarettes, the law doesn't currently affect flavored OTPs. And with flavors like grape and chocolate, the tobacco industry has their sights set on youth. Here is an example of a loophole in Wisconsin and some other states. They allow some tobacco products to be treated differently than cigarettes, making these fruit-flavored tobacco products cheaper and more accessible to Wisconsin youth. Functionally, little cigars are cigarettes. However, because they are wrapped in brown paper containing tobacco, they have been misclassified in law as other tobacco products. Not only are these products cheap, they are also deadly and not a safe alternative to cigarettes. All cigarettes are taxed at $2.50 per pack. Why should little cigars and other cigarette-like products be treated differently? Next, we will cover lung cancer screening information and resources available. Some of you have been with the American Lung Association for a while and know these stats like the back of your hand. But for those who are new to lung cancer, let's share some of these facts. Did you know lung cancer is the #1 cancer killer of both men and women? It kills more people than breast, colon, and prostate cancer combined. The main risk factor of lung cancer is tobacco smoke, but it also can be caused by an invisible gas called radon and certain types of air pollution. In some cases, we don't know what actually causes lung cancer in a person. Lung cancer is a cancer that starts in the lungs. A cancer that starts somewhere else but moves to the lungs is not considered lung cancer. Because of the few nerve endings in the lung, there are very few symptoms in the early stages. Most people don't develop noticeable symptoms until the cancer has spread, when it is harder to treat and the prognosis is worse. There are two main types of lung cancer, small cell and non-small cell, but various subtypes within those types. Small cell is more aggressive and non-small cell is more common. Much progress has been made in new drug development for non-small cell cancer, but almost no progress has been made in the last decade for treatment of small cell cancer. If you have any questions about the treatment and diagnosis of lung cancer, please contact your local American Lung Association staff person. As mentioned before, secondhand smoke impacts lung cancer. Around 7,330 cases of lung cancer each year are caused by secondhand smoke. Exposure to secondhand smoke makes it harder for lung cancer patients who smoke to quit smoking. Smoking during lung cancer treatment makes the treatment less effective. Patients with non-small cell lung cancer, the most common type of lung cancer, who are exposed to secondhand smoke have reduced overall survival and reduced progression-free survival, the length of time during and after treatment when the cancer does not grow or spread. Lung cancer patients exposed to secondhand smoke are more likely to die than patients who are not. There is no safe level exposure to secondhand smoke. In 2006, 7,330 lung cancer cases were attributed to secondhand smoke. Secondhand smoke exposure leads to higher death rates among patients with certain types of lung cancer. Barriers to quitting, so spousal smoking and exposure to secondhand smoke in the home, influence lung cancer. Interventions targeting smoking cessation in lung cancer may be most effective if they address secondhand smoke. In 2002, the National Lung Cancer Screening Trial launched. It enrolled over 50,000 current and former heavy smokers between the ages of 55 to 74. It compared two ways of detecting lung cancer, the low-dose spiral CT, or LDCT, and a standard chest X-ray. Results showed that screening individuals with the LDCT scans could reduce lung cancer mortality by 20% compared to a standard chest X-ray. The criteria for screening eligibility is based on the enrollment of the NLST. At this time, screening is not recommended for individuals who do not meet this high-risk criteria. In order to be considered high risk, you need to be between the ages of 55 and 80, have a 30-year pack history of smoking, which means you smoked a pack a day for 30 years or 2 packs a day for 15 years, and are a current smoker or quit smoking within the last 15 years. Here are a few lung cancer resources offered by the American Lung Association. For screening, please visit savedbythescan.org or lung.org/LC screening. For resources to help lung cancer patients, please visit lung.org/lung-cancer. For general lung information, please call our lung helpline at 1-800-LUNG-USA.
We will begin to transition and discuss the stages of change, which is also known as the trans-theoretical model. The trans-theoretical model is based on decades of research. The model states that individuals move through a series of stages during the adoption of healthy behaviors or the cessation of unhealthy ones. These stages are formally known as the stages of change. The stages are pre-contemplation, which means that you're not ready to quit. Contemplation, which means that you're thinking about quitting. Preparation, this means that you are ready to quit. Action, you are quitting. Maintenance, you are staying quit. And lastly, termination, you are living quit. Research suggests that in any given population of people who use tobacco, 40% are ready to quit, 40% are thinking about quitting, and 20% are not ready to quit. The stages of change acknowledges change as a process. As we previously mentioned, there are several stages included within that process. The stages are pre-contemplation, contemplation, preparation, action, maintenance, and termination. In the pre-contemplation stage, the individual is not ready to quit. They see no reason to quit, and they lack motivation to try. They're also unaware of their addiction. They have no intention to quit using tobacco within the next 6 months. In the contemplation stage, individuals are thinking about quitting. They are weighing the pros and cons of quitting, and they're thinking about how to quit. They know what to do, but they are not ready to start. In the preparation stage, individuals are ready to quit. They are asking others how they did it. They are uncertain, but they are anticipating quitting. They are ready to say goodbye, and they are experimenting with quitting. They are ready to take action in the near future and will probably set a quit date within the next 30 days. In the action stage, individuals have quit. They have taken those concrete steps to quitting. Their efforts are often visible to others, and they get attention from others. They may, however, be vulnerable to relapse, but they have made the decision to quit. They have also quit using tobacco for less than 6 months. In the maintenance stage, the individual is on the way to being a non-smoker. They try to avoid slipping back into smoking, and living smoke-free has become a part of their daily living. The individual has remained smoke-free for 6 months or longer. Lastly, in the termination stage, the individual is living quit. They no longer give in to temptation and have total self-efficacy. Their former behavior is no longer perceived as desirable. Now we're going to begin to transition and discuss the highlights of motivational interviewing. Motivational interviewing is a counseling method that works on facilitating and engaging motivation within the participant by helping them to explore and resolve ambivalence in order to change their behavior. Motivational interviewing is a directive counseling style, which means it is goal-oriented. The facilitator does not tell participants what they should do or try to convince or persuade participants to take action. Instead, they are acting as active partners. Motivational interviewing embodies 3 basic concepts: collaboration and teamwork, evocation and suggestion, autonomy and self-rule. With collaboration and teamwork, the facilitator is collaborating with their participants. With evocation and suggestion, the facilitator is eliciting motivational statements from the participants. With autonomy and self-rule, the facilitator is supporting the autonomy of the participant and acknowledging them as the experts in their own lives. There are 4 broad principles that guide motivational interviewing. You want to express empathy. You want to accurately understand the participant's experience. Number 2, you want to develop discrepancy. Help the participant to see their present behavior and the desired lifestyle change. You want to roll with resistance. Avoid arguing and invite the participant to see new perspectives, being their own change agent. You want to support self-efficacy and provide hope. Help them build their confidence. Motivational interviewing skills include asking open-ended questions, providing affirmations, using reflective listening, and providing summary statements. Motivational interviewing encourages the use of open-ended questions. An open-ended question is a question that requires a full answer using the participant's own knowledge or feelings. These questions are objective and result in an answer with many words. If the answer to your question can be yes or no, or a single response, then it is a closed-ended question. We're going to take a moment to reword the following questions to transition them from open-ended to closed-ended. Number 1, do you realize the health consequences from smoking? An open-ended question would read, what are the health consequences from smoking? Number 2, is quitting smoking important to you? An open-ended question would read, why is quitting smoking important to you? Number 3, how many cigarettes do you smoke on a weekday? An open-ended question would read, why do you smoke cigarettes during the weekday? In addition to asking open-ended questions, you want to also provide those affirmations. Affirmations are statements and gestures that recognize the person's strengths and acknowledge behaviors leading in a positive direction, no matter how big or small. You want to provide those affirmations by making the following statements to your participants. You have a lot of great ideas on different alternatives to use when a trigger occurs. That's a good suggestion. You handled yourself really well in that high-risk situation. I appreciate that you are willing to try the deep breathing exercises, even though it isn't something you normally do. These affirmations will provide your program participants with positive statements that will help them to continue with their tobacco cessation journey. In addition to providing positive affirmations, you also want to utilize reflective listening. Reflective listening is a way for engaging others in relationships that build trust and foster motivation to change. Reflective listening helps to overcome any roadblocks to effective communication and ensures that there is no misinterpretation of what a person needs. There are 3 basic levels of reflective listening: repeating or rephrasing, paraphrasing, and reflection of feelings. When you're repeating or rephrasing, you're repeating or substituting synonyms or phrases, and you're staying close to what the speaker has said. When you're paraphrasing, you're making a restatement of what the speaker has said, and the meaning is inferred. When you're reflecting their feelings, you're emphasizing emotional aspects of communication through feeling statements. This is the deepest form of listening, reflection of feeling. Reflective listening is one of the most important and most challenging skills utilized in motivational interviewing. The crucial element of reflective listening is how the facilitator responds to what the participant says. The facilitator forms a reasonable hypothesis about what the participant means and or feels, and then voices this hypothesis in the form of a statement. There are 3 types of reflective listening statements: simple reflection, amplified reflection, and double-sided reflection. Simple reflection is the simplest approach to reflect a participant's statement with little or no elaboration. This acknowledges and validates what the participant has said and may elicit change talk. Amplified reflection reflects back what the participant has said in somewhat of an exaggerated form. Amplified responses must be supportive, straightforward, and matter-of-fact. Double-sided reflection captures both sides of the participant's ambivalence. It acknowledges what the participant has stated and adds to the other side of the participant's ambivalence. We're going to use reflective listening to respond to the statement on your screen. I have been smoking since I was 12 years old. After 30 years of doing this, I will be lost without a cigarette. You can respond by saying, so you're saying after 30 years of smoking, you will be lost without a cigarette? You're responding by simply restating what they said to acknowledge their statement. This is a form of reflective listening, simple reflection. The fourth and final skill of motivational interviewing is to provide summary statements. Summary statements are a more detailed form of reflective listening. They help to ensure that there is clear communication between the speaker and listener. Summarizing can also provide a stepping stone towards change. When summarizing, you want to first begin with an opening that lets the participant know you are summarizing what they just told you. You can do this by using the following statements. Let me see if I understand. Here is what I've heard. Tell me if I've missed anything. Second, you want to recap what they've told you in a clear and concise way. And last, you want to end with an initiation for them to correct you on anything you misunderstood or lacked. You can do this by asking, is there anything you want to add or correct? In addition to providing summary statements, you want to roll with resistance. Some people feel guarded or defensive about smoking. Rolling with resistance prevents a breakdown in communication and allows the person to explore his or her views. The four main categories of resistance are arguing, denying or negating, ignoring, or interrupting. If the participant is arguing, the participant challenges the expertise or integrity of you as the facilitator. If the participant is denying or negating, the participant expresses an unwillingness to recognize a problem, to accept responsibility, to cooperate, or to take advice. If the participant is ignoring, the participant is paying little or no attention to you as the facilitator. And if the participant is interrupting, the participant frequently stops and disrupts you as the facilitator. When you're rolling with resistance, there are 5 things that you can do to address the resistance. You want to avoid arguing. Do not directly oppose resistance. Offer new perspectives. Don't impose them. Acknowledge the participant as a primary resource in finding answers and solutions. And understand that resistance is a signal for you as a facilitator to respond differently. Another technique you can utilize with motivational interviewing is to incorporate scales into your discussion. You first want to ask the participant a question and have them rate themselves on a scale of 0 to 10. Once they give you the number, you reflect their answer back to them while asking why they didn't score themselves higher or lower. This technique evokes the participant to identify their strengths or reasons they should do it, and not their weaknesses or reasons they shouldn't. Let's use the tobacco cessation importance and confidence scales as an example. Providing the participant with the 2 scales shown on your screen, you first want to ask the participant 2 questions above and have them circle the answer on each scale. If they respond with a low answer, you can ask them why their answer was low, or if they respond with a high answer, you can ask them why they rated themselves so high. In addition to offering motivational interviewing skills, here are some motivational interviewing tips. Tip number 1, have a client-centered conversation. Change talk is the participant's own argument for changing his or her behavior and will always be more powerful to the participant than your argument. So have that conversation with your participant and focus on eliciting change talk. Tip number 2, acknowledge and encourage change talk. When you hear a participant's change talk, acknowledge it. Your participant is exploring behavior change and inviting you to join them. Some statements you can make to acknowledge their change talk. You can say the following. What would you like to see different about your current situation? What makes you think you need to change? What will happen if you don't change? And what will be different if you quit smoking? All of these statements can acknowledge and encourage change talk from your participants. Help clients explore and resolve ambivalence. As frustrating as your ambivalent participants can be, remember that this is a rich source of change talk. It is a normal part of human nature and a natural component of change. Never say, yeah, but. Showing empathy will permit you to express your own opinions within an environment of mutual respect. Empathy flows naturally from a client-centered approach. When you accept the client's perceptions, values, and concerns without judgment or blame, you facilitate understanding. Empathy does not imply agreement, and you can offer it without endorsing their beliefs or actions. However, you want to be empathetic. Tip number 5, you want to roll with resistance. A client's resistance is a clear signal for you to respond differently. When you encounter resistance from a participant, stop talking, listen, put yourself in the person's shoes, and hear things from his or her perspective. Resistance talk is the opposite of change talk and moves people away from change. Tip number 6, you want to deliberately develop discrepancy. Developing discrepancy stimulates behavior change because it creates internal discomfort. Exploring the gap reduces ambivalence and encourages clients to move forward. You're widening the gap between the status quo and the desired future. By doing so, you're developing discrepancy and stimulating behavior change because it creates internal discomfort. Exploring the gap reduces ambivalence and encourages clients to move forward. In addition to utilizing the previous motivational interviewing tips, you also want to utilize effective communication techniques. They are as follows. You want to clarify and elaborate, acknowledge, listen, restate, have good body language, use open-ended questions, ask questions for understanding, and reinforce and praise. A good facilitator communicates by also doing the following. Work with the language of the participant. Don't impress your language upon the participant. Ask permission to give options before you do. And let the participant find solutions. Empower the participant to believe they can change. Help them find the answer. Eliciting change talk is when participants talk about solutions, about benefits of change or disadvantages of staying the same, about how to change, and about ways to resolve a problem. The more change talk someone demonstrates, the more likely it is they will move toward making a change. Change talk can be identified by utilizing the darn C model. The D, identify their desire to change. The A, identify their ability to change. The R, identify their reasons to change. The N, identify their need to change. And lastly, the C, identify their commitment to change. As a facilitator, you also want to acknowledge signs of readiness for change. Participants will display the following signs. They have decreased discussion about the problem. They start by saying, I don't know how I could live without smoking. And their statements transition to, I think I could cut down gradually and then quit. They have increased language in favor of the change, and they ask questions about the change. They'll do that by asking the following. What did you do to quit smoking? Another strategy that can be utilized is to negotiate a change plan. Work with the participant collaboratively to set specific goals. Consider a range of change options. Record the plan and elicit commitment from the participant. We've discussed motivational interviewing extensively. Now we're going to transition and discuss brief interventions. Brief interventions in the 5 A's. A brief intervention is a 3 to 5 minute conversation with a tobacco user to find out if they are ready to make a quit attempt. And if so, help them get started. Brief interventions have been shown to increase the number of quit attempts and the number of people who quit for good. To do a stage-appropriate brief intervention, follow the 5 A's. Ask, advise, assess, assist, and arrange. The first step of the 5 A's is to ask. You want to ask each participant about his or her tobacco use at every visit. You can do this by asking the following. Do you smoke or use any other form of tobacco? It's important to ask at each visit because the status may change. The second step of the 5 A's is to advise. You want to advise in a clear, non-judgmental, and personalized way. You can do that by stating the following. I understand quitting is difficult and may be a little scary, but it is the single best thing you can do for yourself and for your family. You want to advise them to quit in an empathetic and supportive way. The third step is to assess. You want to assess each participant's readiness and interest in quitting. You can do that by asking the following. Are you ready to try quitting smoking? If you assess your participant and they are not willing to make a quit attempt, tell them you understand quitting is difficult. Let them know you are willing to answer any questions they have now or in the future. Let them know that you are supportive of them moving forward. Next, you want to assist your participants. Assist each participant with developing a specific quit plan that includes both counseling and medication. Counseling to assist with the behavioral and psychological challenges of quitting, and medication to assist with the physical challenges. You can do that by stating the following. Let's get started by picking your quit date. Then we'll figure out what you need to do before then. I know the American Lung Association has some great resources to help you quit. Let me tell you about them. The last step in the 5 A's is to arrange. You want to follow up with the individual within 1 week of their quit day. You can do that by phone, email, or in person. You want to address any challenges in their quit attempt and adapt their quit plan as needed. You want to assess whether the method of treatment is being effective and address any challenges they may have. Some changes may be necessary to ensure the right combination is in place to give the best possible chance of that individual's success. You can do that by stating the following. I'm going to put a note so we remember to talk about this next time. It's okay to have quit by then, but let's keep working toward this goal together. While conducting a brief intervention and assessing your participants' readiness to quit, you will make the following statements. The ask. Do you smoke or use any other forms of tobacco? The advise. Quitting isn't easy, but it's possible, and it's the single best thing you can do for yourself and for your family. The assess. Are you ready to try to quit smoking? The assist. Let's get started by picking your quit date. Then we'll figure out what you need to do before then. I know the American Lung Association has some great resources to help you quit. Let me tell you about them. The arrange. I'm going to put a note so we remember to talk about this next time. It's okay if you haven't quit by then, but let's keep working toward this goal together. You can utilize the following statements to conduct a brief intervention, even if your participants are not ready to quit. You'll start by asking, do you smoke or use any form of tobacco? They'll respond, and you'll follow up by saying, it can be a little daunting, but quitting is the single best thing you can do for yourself and for your family. And quitting means you won't have to go out for a smoke break when it's raining or in the middle of the winter. You'll also follow up by saying, are you ready to try quitting smoking? They will respond. If they say no, you will follow up by saying, quitting isn't easy and you have to be ready. I'll check back with you again in the future, and you can always reach out to me if you want to talk about it. In the meantime, here are some resources to learn more. And lastly, you will provide those resources. In addition to conducting Ask, Advise, Assess, Assist, Arrange, the 5 A's as a brief intervention, you can also conduct Ask, Advise, Refer. You will do that by stating the following. The ask. Do you smoke or use any form of tobacco? The advise. You know, quitting is the single best thing you can do for yourself and for your family. Are you willing to give it a try? The refer. The American Lung Association would be happy to help you quit smoking. You can reach them at 1-800-LUNG-USA or lung.org. If it's okay, I'll give them your name and they'll reach out to you about quitting. The American Lung Association has several resources to help your participants quit, and we're going to explore those. The American Lung Association has the Freedom from Smoking program. It is voluntary, interactive, and supportive. It has an addiction-based model with a behavior change focus, and it supports the use of cessation medications. We have multiple delivery options. We have our Freedom from Smoking in-person group clinics, which are 8 sessions held over 7 weeks within a small group setting with a maximum of 16 participants, and it's led by a trained facilitator. We also have our Freedom from Smoking Plus program, which is an online platform. We have our lung helpline, which we'll discuss in the next slide. And lastly, we have our Freedom from Smoking Self-Help Guide, which allows participants to independently guide themselves through a tobacco cessation program. Some of these materials are also available in Spanish, which is noted on your screen. The Lung Helpline is staffed by nurses, respiratory therapists, and smoking cessation counselors. It is open weekdays 8 a.m. to 10 p.m. Eastern Time and weekends 10 a.m. to 6 p.m. Eastern Time. Our counselors can answer any lung health topic including tobacco cessation, lung cancer, COPD, asthma, and air quality. Contact the Lung Helpline by dialing 1-800-LUNG-USA. There are other cessation programs that can also be utilized. We'll discuss them in the coming slides. When considering other cessation providers, remember to cooperate, don't compete. It's fine to use other cessation programs as part of this project if another program is already in place, another program is a better fit for this population, and you can coordinate to reach more people or provide a stronger program. Other cessation providers may include state tobacco quit lines, state tobacco control programs, community health centers, local hospitals or health systems, and even other nonprofits. To wrap up, we're going to discuss what you need to do for this project. First, you want to find public housing authorities that need smoking cessation assistance. You can start with the PHAs you're helping with policy implementation. You want to identify, recruit, and train a cessation navigator to serve those PHAs. Support those cessation navigators as they work, and collect data and track their progress. You also want to provide direct cessation assistance and/or refer to other cessation resources. You can utilize all forms of freedom from smoking or other programs if appropriate. Lastly, you want to track the number of residents helped. Congratulations! Now you're a trained cessation navigator. So what do you do? And what can you do? We'll discuss that in the coming slides. As a cessation navigator, you will talk with your friends and neighbors within public housing settings about their tobacco use. Unfortunately, cessation navigators are not considered freedom from smoking facilitators. You will also need to provide additional training regarding local cessation services. Cessation navigators must also report data back to us regularly. And you will focus on tobacco interventions and referrals, then add the lung cancer screening component to your conversations with residents. When considering new cessation navigator candidates, it's ideal to hire residents when possible. Many already conduct health programs of some kind. You can pay stipends or underwrite part of your salary. You also want to look for natural leaders and trusted members of the community when seeking cessation navigator candidates. Community health centers serving public housing may also have good cessation navigator candidates. These are good things to consider when considering new cessation navigator candidates. As a cessation navigator, when talking to multi-unit residents about quitting, these are some things you want to remember. Smoke-free air policies are about smoking, not smokers. Many tobacco users may decide to make a quit attempt when a property becomes smoke-free. However, not every tobacco user will decide to make a quit attempt when the property becomes smoke-free. Don't be judgmental, confrontational, or argumentative. Try to always be respectful, empathetic, and possible. And always remember to roll with resistance. We have come to the end of our Cessation Navigator training, so we want to provide some resources to you. To get in contact with your local lung association office, visit lung.org. To find our smoking cessation resources, visit lung.org/FFS or freedomfromsmoking.org. To find our smoke-free multi-unit housing resources, visit lung.org/smoke-free housing. In addition, also expect to hear from your local lung association contact. He or she will follow up with you to provide your certificate of completion, to also give you those Cessation Navigator resources, and to frequently check in with you to track your success. Thank you again for participating.